their name. If everyone wants to put their name and where they're from in the chat, we can virtually introduce ourselves to each other.
We're excited to have our workshop presenters here talking about a resident-led residence teachers program. I am personally excited about that because there's a lot of work that goes into creating these types of curriculum. So excited to hear this talk. I'd encourage people to also not hesitate to chat comments throughout. I think no matter what, there are lots of things that we can share together throughout their presentation and kind of hopefully spur other ideas and thought processes. All right, take it away.
Perfect. Thank you for that introduction, Tammy. So we're really excited that you decided to join us for this last day of the APGO Faculty Development Seminar. We are looking forward to sharing our work and having a robust discussion regarding resident teaching on the OB-GYN clerkship. Our talk is about how to get our residents to rocket to a higher potential by using a resident-led resident as teachers program. First, I'm very excited to give this presentation with other members of our graduate medical education team at Baylor College of Medicine. My name is Bonnie Raton. I have been working on the Resident as Teachers program since 2016, and I've been in the role of Associate Residency Program Director since August 2020.
I'm Matt Carroll. I was a Baylor resident, and I've been working as the assistant program directors for the last year, as well as one of the Academy of Resident Educators faculty advisors for the last 2 years.
I'm Charlotte Kilpatrick. I serve as our program director and our vice chair of education here at Baylor, and I'm happy to work with these awesome, excellent, outstanding student and resident educators.
We have 3 main objectives through this talk. The first is to identify barriers to effective resident teaching on the OB-GYN clerkship. The next is to describe our response to these barriers, the creation and implementation of a resident-led resident as teachers program. And finally, we would like to emphasize the importance of buy-in and scholarly work in terms of truly impacting system change. So first, to set the stage, Houston, we have a problem. As you all know, Baylor College of Medicine is in Houston, which is one of NASA's main 2 launch sites. This quote was made popular after Apollo 13 and after the movie came out, but it very accurately describes the environment in terms of our resident teaching when we started this program. Over the next slide, I'm going to describe the background and then the rocket fuel, how we created this program. Now, as many of you know, every year medical students fill out the AAMC Medical School Graduation Questionnaire, and they always have to answer this question. Residents provided effective teaching during their clerkship. As you all know, probably too, this lags behind the learning environment by about 2 years because it's only given to graduating students. So this questionnaire from 2018 describes learning environment from 2016 in our institution. Although these are national numbers, it pretty accurately reflects the numbers at our institution. And as you can see, OB-GYN residents are rated the lowest in terms of the 7 core clerkships in terms of effective teaching. Only 73.8% of students rated them or agreed or strongly agreed that residents provided effective teaching. If you look over to internal medicine, they're much higher, 92.9. Pediatrics is also doing a good job. Only surgery is kind of close to us in terms of how our residents teach. So we actually want to make this interactive and hear from you. So if you guys can either chime in or put in the chat, why do you think this is? What do you think are the barriers to effective resident teaching on the OB-GYN clerkship? I'm going to give you a moment to think about that. And again, you can either shout it out or just write it in the chat in terms of barriers that you see.
Bonnie, can you see the chat effectively, or do you need me to read things out?
No, I can see the chat. I have it. So thank you, Tammy, for sharing time and energy. Oh, they only respond to active, assertive students. Resident perception of educating medical students as a burden. Oh, that's a great one. And then Teresa said, or teaching. OR teaching, okay, not OR teaching, operating room teaching. Perfect. Thank you for contributing those things. At the beginning of our program, we actually did focus groups with medical students to kind of try to see what their view were of resident teachers. Thank you, Jane, for sharing too. Not knowing how to effectively teach in short downtime, uncertainty of how to teach and what can be valuable. And the main themes we got from these focus groups were that they thought the OB-GYN experience was passive because of the strain of patient autonomy, and also because at least at our institution, they had preconceived notions that our rotation was going to be very malignant. And so our residents had to overcome that barrier in addition to the barriers that were listed here. So our solution to this, in 2016, we introduced the Academy of Resident Educators in our OB-GYN residency. This had been an initiative first done in the pediatrics residency in our program, but we adapted it to our OB-GYN program. So the mission of this academy was fourfold. The first was to assist residents to develop as future clinician educators. The second was to improve the teaching abilities of residents to really improve our learning environment. The third was to promote a culture of residency teaching and education in order to make it so that teaching was the expectation instead of the exception. And a final and very important goal was to attract OB residency applicants to Baylor College of Medicine that actually had an interest in teaching and wanted to make education part of their future. The Academy of Resident Educators has two main components. The first component is a steering committee. This is made of a PGY year level resident from each year and 3 faculty advisors. The main job of the steering committee is to organize 4 educational workshops per year that are given during didactic times. These workshops could range on topics from professionalism to feedback. And we always have a workshop at the beginning of the academic year about how to give a short talk or a chalk talk to medical students. This committee also reviews educational portfolios, which I'm going to go through in the next slide. While the workshops are available to all residents, for those residents that have a more robust interest in education, they are able to put together an educational portfolio. In this portfolio, they need to document time they spent in education in particular areas. The first is direct teaching. Any teaching they did to medical students, they need to keep a log of this and have 10 hours of direct teaching at least. 5 hours of educational leadership. This could be chairing one of the subcommittees of the academy or doing a leadership project. 5 hours of surgical skills education. This could be going with the students to the simulation lab or participating in the clerkship simulation lab. And 5 hours of personal development or research. Part of their personal development could be going to one of these APGO meetings. At the end of the 4th year, they also need to write a personal statement on their role as a clinician educator. This whole portfolio is reviewed by the steering committee at the end of the 4th year. And if the portfolio is acceptable, they are recognized as a distinguished resident educator at graduation. This also mimics the promotion process at our institution. So it sets people up to understand what it means to be an academic OB-GYN educator. I'm now going to turn it over to Dr. Carroll, who's going to describe the future or what has happened since the initiation of this program.
Thank you so much, Bonnie. So keeping in with the themes of the conference, we're going to talk about Moonshot, our progress from that initial conception, and the things we're focusing on now. And we can go to the next slide. So things grew out of the academy pretty naturally, and it was primarily based on resident interest. And so these are kind of the 5 big facets that the residents developed, and we've kind of been supporting them in the last couple of years. So and a lot of these linked together. I really wanted to tie this kind of web together, but then it got very busy looking. But I think everyone can understand that a lot of the medical student mentorship ties in with clerkship education and development of educational resources. So for medical student mentorship, we already have a very robust interest group in OB-GYN, and the Academy of Resident Educators has been set up to be the mentorship leaders for students who are interested in going into OB-GYN, coordinating different events, activities, as well as tying them into the research projects that they're working on, both educational and otherwise. tying in that early educational research coordination. As faculty advisors, we've always been trying to mentor our residents through different questions and educational research projects. A lot of those have actually come from their conversations with the medical students about how we can improve that. One that we particularly worked on was our development of educational resources. We created structured worksheets to kind of combat that time, the issue with residents needing a lot of time to do helpful teaching. So we generated these structured worksheets that were able to be used quickly and on the fly so that they can provide high value teaching in a short time with not a lot of preparation beforehand. And we published on doing that with residents at the time. Seeing the benefit of the educational resources, residents had been participating in kind of Baylor-wide student teaching efforts, including development of chalk talks, focusing on 1-minute preceptor and other kind of educational tools. And so they developed a learning library for the students as well as for the residents to have more guided topics to go through. And then the most recent development is a bastion of video chalk talks that all of our interns do, guided by some of the steering board members when they enter residency. Since we're very fortunate at Baylor to kind of have existing Academy of Resident Educators at other departments, we have a liaison to coordinate with other groups, events, things that they're doing they found to be high yield that we can bring to our residents and our students. And then they work closely with the undergraduate medical education team to make sure that residents who are interested are able to give some of the clerkship lectures, to be present for surgical sim and things like that. So we try to tie all those things in together and take care of it that way. And so those are the kind of things that grew out of the steering committee at first. And if we can go to the next slide, I'll talk about each of the things that we're really focused, that our residents are really focused on now and interested about. Can you load the first pillar? And so what I think is one of the most exciting things that we've been doing with the residents is the Education Journal Club. So we already had a quarterly journal club just for review of interesting new literature and critical analysis. It also served as a nice time pre-pandemic to have the residents together for some food and beverages sometimes to do review of an OB-GYN and an OB and a GYN article. Starting a couple of years ago, we've added quarterly education research where we have consistent mentors taking a resident, usually a PGY1, through an interesting paper. And what I think this has really allowed us to do is show them different types of research that they might not have considered while they were medical students. An emphasis on qualitative research, in different perspective pieces on educational theory and things like that, as well as papers from MedEd Portal and other innovation and workshop things that they can apply to their own life. So that's been really exciting. And looking forward to the upcoming year, we're thinking about having our upper level residents serve as the mentors for our lower level residents to kind of get them practicing at mentorship, as well as doing some critical analysis of the current medical education literature. If we could go to the next pillar. Like I mentioned before, medical student outreach has always been a really important facet of this, through the interest group, through the clerkship lectures, clerkship didactics, as well as working with the undergraduate medical education team to see what the general feedback is after clerkships, find out where we are having really good teaching, really good experiences for the medical students, and then where are the pain points? What are the sub-rotations that are not as valuable, and are there ways that we can improve them? Because the residents are ubiquitous. So they're really the primary teachers for the medical students, and they have a better idea of how to work on and change things. So medical student outreach has been a really important concept there, as well as helping medical students who are interested in the field get the kind of research that they're involved and get them involved in research and really build their portfolio for application to residency. And then, like Dr. Rattan mentioned before, didactics. We do quarterly workshops or didactics. The ones that she's mentioned are the ones we really focus on. Beginning of the year, how to give a chalk talk so that the interns have a couple of skills in their back pocket to really teaching the medical students, because what we found is that there's kind of a hesitancy. There's a little bit of imposter syndrome that they don't know as much and are a little hesitant to teach the students, but we kind of build up their confidence, give them the skills to go ahead and address that so that they're able to hit the ground running with our medical students. Other things we work on are other really helpful medical education skills that I'm sure everybody here is familiar with that our residents have not always been exposed to. 1-minute preceptor, giving chalk talks, little things like that. As well as we have some of the excellent medical education speakers from Baylor wide come in and give a feedback on, or give a lecture on feedback. That's what we've got coming up next. 2 of our internal medicine, medical education kind of rock stars who really do a terrific job are coming in to give that lecture again. And other times we just have a check-in with the residents to see what's working out, what are their pain points with the medical students, how can we have the experience grow and get better both ways. All right, if we can move on to the last slide, I wanted to take some time and talk about how we got here, how we're doing a little bit, and then get feedback and see how y'all feel about this idea, things that sound like they make sense, things that don't sound like they make sense, and your take from a different institution. So the most important thing, I think, for growth of the Academy of Resident Educators and why it's been so successful is the residents led the growth. We were there as advisors, absolutely gave them a concept and foundations, but they were the ones who said, I really want to work with the medical student interest group. They really want to be involved. We have lots of opportunities to teach them, get them involved in research and things like that. We don't feel comfortable giving feedback to learners who may not be as prepared for constructive criticism as in the past, and how to meet the learner where they are. So then when we got that feedback, we worked on that. So it's primarily been resident growth led and getting feedback from them. But I'd love to hear kind of if these ideas work, if you think this would work at your institution, where do you see, is this what your residents need to be better educators? Are there things you would be thinking about doing instead? And again, you can put that in the chat or come off of mute, whatever is easier for y'all.
Hi, I'm Teresa. I think the Academy is a great idea. We've implemented some of the similar concepts of 1-minute preceptor and lecturing on feedback, how to give good feedback, because it's so important to advance learner skills and reflect on their experiences. But the Academy structures and pulls everything together and then formalizes it from a medical education perspective for the residents and gives them the tools, which I think is fantastic. I would love to have an Academy where we are for the residents. Thank you.
Excellent. Thank you so much for that. And then I saw Dr. Dean mentioned thinking of a streamlined version for a smaller program at 3 per year. I think that's definitely possible, especially if you have 1 or 2 engaged residents to build it from the ground up with you. I think that would work really well. And in a kind of intimate setting, I think there's a lot of leaps and bounds you can really make with the right residents.
Matt, do you see this other question? How do you make sure that you have protected time for your residents to participate in educational activities? So one of our first things is that the clerkship didactics or the clerkship sim lab, for most of our time as the Academy, was at the same time as resident lectures. So we would excuse residents from their lectures if they were going to teach at the clerkship for the clerkship. We also have residents give some of the clerkship formal lectures, and because of a supportive residency director, Dr. Kilpatrick will go into this a little bit, we are able to support residents who want to give the formal lectures to the big group of medical students too, because we have support from above.
Yeah, I definitely think that's one of the advantages, obviously, of a supported program, but also we have a little bit of flexibility with the size of the program. But medical student didactics and resident didactics being at the same time, I think has been a huge boon for that process to continue.
Yeah,
Does anyone?
I agree, guys. I think I think we all know that if you're going to learn something, the best way to do that is to try to teach it. And so I'm a big believer that when the residents participate in the student clerkship didactics, they're really learning a whole lot, and it's really solidifying their own knowledge around whatever clinical topic it is they're trying to convey at that particular time. So we're very flexible. We did get some pushback from some of our faculty that participate in didactics, like, where are the residents? But once you explain to them, that they're also teaching, and that, we want to promote an environment that encourages our residents to become academic teachers, they get on board. So, but super question, and Matt's point also is well taken. Our program is a little larger, so we are able to find time for the residents that maybe smaller programs would have a challenge with. But I do think, having even been at a smaller program before, the main thing is making sure that your leadership, which we'll talk about, is on board.
And right before we get to that, because I'm really excited for Dr. Kilpatrick's section of the talk, I just wanted to talk about a couple of difficulties we've been having and things that we're kind of working through, because I don't want to make it seem like this has just been, slam dunk, full speed all the time. I think everybody has felt the kind of variation and difficulties in the pandemic with COVID. I think for us, it's resident led. So resident engagement has been the kind of important thing that we need to nurture and keep going. And so I think that's why taking a look at it and continuing to reassess what is the best structure that's going to enable the residents to flourish has been something that's important for us. And then again, with resident engagement, with having somebody change the level, we have the third year kind of as the leader of the executive committee, with the fourth year mentoring them. Depending on your the different people, you have a different level of engagement and ability to take on certain responsibilities. So we're finding the best way to support them and keep everybody engaged so that we can have this, foundation and structure that we're really proud of, continue to keep moving even in difficult times and with changes in leadership. So those have been difficult, but here we are. Dr. Dean, that's a terrific question, and I'm not quite sure of the exact difference in the model there. I don't know if Dr. Rattan or Dr. Kilpatrick can comment.
We believe residents as preceptors and resident as teachers. To us, I see the difference that you're talking about, Dr. Dean. But I think resident as teachers is the most common way that it's referred to in the literature. Unfortunately, the acronym is RAT, but that's the way people use it in the literature. We have changed, as we were publishing, we did change distinguished resident educator to distinguished educator, because someone very aptly pointed out the acronym is DRE, which some people will think of as some other thing in medicine. So we are open to name changes, but I think we kept it resident as teachers because that is what it's referred to at most in the literature. But residents feeling like they're preceptors and really involved in the development of the medical students, we really understand your point, Dr. Dean. And then I think Dr. Sana also had a comment. Thank you for this comment. Packaging this model creates it wonderful and multifold, and we wanted to really hit education from many different directions. You packed so many outputs into this, in addition to the direct teaching, but also the interest group task, a pool to help with student-related tasks, education journal club, and it's just so that all of our residents can have a small task to work on, but again, the steering committee and the faculty advisors are just making sure it's all keeps on going.
And that's all I had.
Yeah, so one of the other that Robert brought up, a role as a preceptor is a little bit different than what we classically think of as a teacher. So in that regard, we do like to see that our residents are promoting our students to be to self-assess more and to be a little bit more self-directed. Oftentimes, and I feel like the pandemic has worsened this, is our our students are really struggle to kind of find their way in the clinical learning environment without a whole lot of very specific expectations, which was not always the case. So yeah, it is nice that we get some, but the rat designation is not, it's not awesome. Leadership development. Well, yeah, and if we had another hour, we'd tell you about our foray into leadership as well. But we're, Bonnie, you want to say anything about some of the
Sure.
leadership stuff?
While I'm going to do that, I'm going to stop sharing so you can share your slides.
Okay.
So yes, that's really interesting, Dr. Sun, because as part of this program, one of the residents who first started the program, she wanted a project. So we actually together, as part of the Academy of Resident Educators, did a needs assessment on resident leadership skills specific to obstetrics and gynecology. Using those competencies built from that needs assessment, we have built a leadership curriculum that is facilitated by a very senior level mentor, proctoring 3 junior mentors and giving a leadership skills development program for our residents. So but I completely understand what you're saying. It all ties into each other: leadership, teaching, wellness, it all kind of ties in with each other. So I understand how the difference is in phrase.
Can you see my screen okay now?
It's perfect.
Yeah. Okay, all right. So yeah, I just did a whole, we just did the board. So I think I know how to do this share screen thing, but I appreciate it. Are most of us in the clerkship folks or residency folks, or who am I talking to? I'm just trying to get an idea. I've done both. The clerkship was really my favorite, to be honest with you. But for some strange reason, I got into the residency program. Don't ask me why. And once you get in here, it's like you can't get out. But the student clerkships were my first. When I first got to Baylor too, I used to have to say all the time, we wouldn't have much of a medical school without medical students. And at first, people would look at me kind of funny, and then they would kind of sort of realize how important that statement is. And I communicate that to our applicants who apply to our program, and I communicate that to our residents who work with our students all the time. So where are we going, or what kind of do I want to try to convey to you? Well, some of the things I think I'm going to talk about here, you could likely use for any change initiative. And I say this to Bonnie and Matt all the time, but everything is change. It's all change. Anything that you are doing in your clerkship, in your residency program, it all works on the principles and the foundations that are involved with change. And I say this all the time too, and it sounds kind of simplistic, but the only person that likes change is a baby in a wet diaper. Nobody likes change. And so it is very challenging to mobilize a group, especially one that is as large as ours, and get them on this page of being more interested in educating our medical students. And so it probably will, if you decide to run in this direction or move in this direction, to make what you think is progress in a very quick period of time. I remember when Bonnie and I sat down and conceptualized a lot of this stuff, she had meetings picked out and was ready to go. And I was like, yeah, okay. And I thought to myself, this is going to take us 3 years. And it did. And so getting to a point to where, and we're still not done, as Matt kind of very politely alluded to, the leadership in the residency program changes every year. And as it changes, the academy itself has changed. In fact, we need to kind of sort of sit down and look at our leadership model right now for the academy. So let me just get started with some of the change stuff here. Oops. So buy-in, before I get to there, and I have a picture of our chair here who's flying a helicopter. not because I'm enthralled with my chair, which I guess I am a little bit, but it's to remind me of how important it is to get those folks that are in your learning environment and in your organization on board with the ideas that you have. And I'll give you an example. And this was 10 or 15 years ago, and we had this great idea. Okay. Francisco, my colleague, who's also a urogynecologist, we were going to teach cystoscopy to our residents. We thought it was we were at the SGS meeting and they had a model. That's a long time ago. And so came up with the idea and we pushed it through the IRB and we talked with our program directors and stuff. And we said, because there was 2 at the time of the residents that we worked with. And they seemed on board with the idea. And we mentioned we were both on the anatomy lab committee. And we said, well, we'll mold it, morph it into our anatomy lab, and we'll take the residents out as part of the pre-test and post-test and all that stuff. And we talked with the director of the anatomy lab, the person who, one of our colleagues who was really in charge of the anatomy lab. But I don't think we truly got his buy-in. In fact, I'm positive we did not. And so our project, which conceptualized, was a super idea, and it was really meant to improve upon the residents' cystoscopy skills, really as an educational project, just took a complete and total nosedive. And we were so dismayed. We did not understand because it was such a good idea. It was obviously addressing a need that our residents had, which was really to develop their cystoscopy skills. But I'll never forget it. And it was a lesson that I learned on how important it is to generate and get buy-in from your colleagues. Because if you don't, you are doomed. So, and I'm sure you will. So I'll give you some quick ways on how to generate some buy-in. First and foremost, you've got to present the facts to these folks, right? Not just because we're physicians and we rely on facts to make all of the clinical decisions that we do every day, but it will give them some real world data that they can then utilize to say to themselves, this is a good idea because it's a real problem. Presenting that data too will likely elicit some emotion. Did you see the data that Bonnie presented to us at the very beginning of the presentation on how poor our residents are perceived in teaching our students? We shouldn't be last, right? Use that emotion that your residents may have, that your faculty may have, because as we know, change is not easy. You've got to have some emotional capital that you can utilize to push this change effort forward. So just the facts, show them that data, and then utilize that emotion to get this thing moving. All right, chunk it. And I'm not talking about golf here, although I chunk it all the time. We were, and I wish we were in person there at Amelia Island. We ended up going anyway, and that's a whole other story. And I chunked it pretty good on the golf courses out there in Florida, but small pieces, okay? Give them a little bit at a time. Don't give them the whole thing because it's too overwhelming. Start with something which was ingenious. It was Bonnie's idea, and Matt did a great job of documenting it. Tiny, teachable pieces of information that the residents will have, because and somebody already pointed out, the residents, the first thing they're going to say is, I don't have any time. Well, we fixed that for you already. We have some teaching tools. They're pre-made. They're in the clinical learning environment. At the time when we started this, so long ago, I mean, we had like printed up pieces of paper, and what else were we doing? I can't remember. But small pieces that they can absorb. And what does that mean? Allow testing. If at first they say, well, I don't like it, or I don't think it's going to work, then you just say, okay, that's fine. If it doesn't work, go back to what you were doing before. 9 times out of 10, they're not going to go back to what they were doing before. They're going to use it, but give them that out. Allow them to test that situation to say, hey, I don't know if this is going to work. Okay, if it doesn't, that's fine. Then you can utilize what you were doing before. Make sure that you're listening. Okay, because in truth, in reality, which is, what I learned many years ago, the relationship that you have with your colleagues and the residents is the issue, right? They don't want to hear or you're going to hear from them, I don't get it, I don't like it, and quite frankly, I don't like you. And so you can tell from that type of emotional response, you've got to develop those relationships with your colleagues and listen to them. Have them get on the same page with you. They need to feel that they're heard around whatever the change topic is, and that will help you gain more buy-in. And then last but not least, which is, I think, my most favorite thing about this particular change effort, is that it's driven by the residents. So the change comes really from the bottom. There's so many change initiatives that we're involved with. I mean, all the time. And one of my old mentors used to say, I don't make the rules, I just swim in the pool. And I tell you what, the pool that we swim in now, from some of the stuff we get from the ACGME, they're not asking us. It's all being pushed down from the top. And you know how frustrating that is when you get this information that's pushed down upon you without your input or perception whatsoever. So don't do that. Right? You're ultimately responsible for the change, but introduce the ideas and let it grow, because it will, if you're attracting the right type of residents that you want to lead some of these teaching efforts. Okay, so that's my takes on buy-in. And Bonnie, you just tell me if I need to speed up, because she laughs at me all the time because I talk too much. So with change, you've got to be able to communicate. And I will tell you this, 9 times out of 10, any change effort I see is under-communicated. So one email about whatever it is you're doing, one time presenting at didactics, one time at Grand Round, it's not going to cut it. Over-communicate the idea, do it in so many different venues, and we're going to get to that in just a little bit. Facilitate, you've got to be able to facilitate whatever that change effort is. You need to remove some barriers, okay? And there's all sorts of barriers in academic medicine, isn't there? And especially in our clinical learning environment. I got an email the other day talking about our OBGYN workroom. And I said, you mean our OBGYN closet? Because we have no space in our learning environment over at one of our hospitals. Recognize those that are on board, okay, or are getting on board, who are becoming part of your change initiative, okay? It is very important to do that, and to do that very early and often, okay? Because that will gain you more people and really begin to even push this even quicker. And then, we work very hard, all of us do, as academicians. You've got to be able to document some of this stuff. Otherwise, it's, just, well, I did this, and you're like, well, where is it documented? It's not documented anywhere. So find meetings locally, regionally, nationally, that you can come up with some ideas and submit some information that you can then document as peer reviewed and make scholarship out of it, okay? And keep in mind, it's not an event change. It is a process, and it changes all the time. And as you're listening to those that are participating in the process, hopefully the efforts that you're putting into place are going to change. Okay, so what are some of the things we need to do in order to get things going? You've got to establish a sense of urgency. The nice part, when we started our Academy of Resident Educators, and it depends on who you talk to if you think this is a nice part, is that Baylor was on probation by the LCME, right? So we had all sorts of ammunition to say, hey, we have got to improve our learning environment for our students. And they would say, well, I don't have time. Or that. Doesn't matter. We have to. Otherwise, the LCME Baylor's going to be in big, big trouble with the LCME when they come back. So we had an opportunity to take something that was already going on at the institution and utilize that in our benefit, okay? So establish that sense of urgency amongst those that are going to participate in that change initiative. Convey the vision that you have for whatever that change is. In our case, it was the Academy of Resident Educators. Bonnie, I think, eloquently described the mission of our academy, which is to foster the growth of our residents as clinician educators by really encouraging them to participate in direct instruction of our students, introducing to them the concept of educational leadership and really professional development. And so as we continue to move forward, because we still, as Matt said, and he was being nice, we've got work to do with our academy right now, you know, and over communicate, okay, multiple venues, multiple platforms. I mean, maybe I'll take a second for those of you that are here to, where can you think of and put it in the chat, or just show your face and say something. Where would you communicate that you're going to start an academy of resident educators? And who would you communicate it to? And then I'll tell you where we did ours. Anybody? I won't bite you. Well,
Well, if I can, I'll just throw some things in there. I
Yeah,
think beyond
go
what
ahead.
you were saying, which is just buy-in from all the different parties. So of course your chair, if you're not the PD, then your PD, your kind of educational titled leadership. I feel like that must be kind of your steering committee group. And so that they can get buy-in. But I also kind of feel like it branches outside beyond that. I feel like this could also be, and I know this is all setting up this concept, but it's such a nice thing to also have as a package that your applicants see, right? There's such a growing body of this concept of being a medical educator that it always like surprises me how many come into from med school into a residency already knowing that that's something that they want to do. And I think you having this is a huge selling point as well in terms of the structure and the formality of it. And to have that kind of label and title, that's something that they can even put on their CV is a big thing. So just kind of, again, you brought that up as well, but I just want to emphasize that piece in addition to all of the different major stakeholders.
Yeah, go ahead, Robert. Great points, Tammy, and I'll get back to that in a second. Go ahead, Robert.
So, I don't think we have anything in our program. So we're a community hospital. It's becoming more university based. We joined from being a community into the Mount Sinai system in New York, but we're still somewhat separate. We have a number of residencies in the hospital, and I don't think we have this program in any of the residencies. So we do have a faculty development coordinator for the whole hospital. So I think it's the sort of thing that, if I just brought it into my department, there might be a degree of resistance to change. But I think if I worked through the whole DME and tried to look for it as maybe as a hospital-wide thing and the different programs, that I might have a better chance at succeeding that way, as saying we want, because I sat there and did the numbers. They said if we got one lecture a week out of residents, and 4 for the year, and they'll say we also do 1 for every rotation on a surgical sim, and that number of 5 hours, out of a year is something to do, not 10, half of what you guys had. Maybe that's a start. So in a small program, I'm thinking of actually starting broader and then trying to hone it in, out of there. So that, I don't know, that's what I have at the moment.
And
Thank you so much. This is great.
Can I just chime in? So we adapted it from pediatrics, and we actually decreased the number for pediatrics, which is a huge department at our program. They had like 20 hours for each thing. So we decreased the number in order to meet the needs of our program. And so I can definitely see that working for you.
Yeah, I think that's a great point. And I am, with all the things the residents have to document, I didn't want it to be burdensome, to be totally honest with you. Every time I turn around, we're in our new GME leadership team is very, they like us to have all of our work and educational hours and all this stuff entered, all that, which is not, I don't think it's any of our favorite things to do. So in that sense, yeah, I didn't want that to be a burdensome thing for the residents in order to learn how to teach, really, to be honest with you. But as far as venues to communicate, oh, go ahead, Jane, sorry.
So I guess for venues to communicate, my immediate thought was like grand rounds, but that's really challenging because, you know, we have academic core faculty, but then we also have a lot of community faculty, and we are across 2 residency programs. So we have core faculty in multiple different institutions. So like your question is really a challenge about how do you actually get the word out?
Yeah. So what is it about grand rounds at your institution that you don't think they let you talk at grand rounds?
Well, I think they would, but it's only going to reach a small portion of the population that
Exactly.
that's
So true. Yeah. That's why you have to do it at so many different venues. So, and you know, Robert was mentioning this too. Maybe he needs to start with the leadership there at GME as a whole. And it's, you know, that was another place we communicated it. When we had our GME meeting, I said, hey, we're doing a residences teachers program. You know, we borrowed it from PEDS or whatever. And, you know, if anybody has any ideas, and that gets word out, because you're right. You're not going to bump into all your colleagues, but the word will start to spread. You know, another venue, we had folks go to divisional meetings and talk about why we were doing this. We did this at the beginning of student orientation, and our clerkship folks work with us. Jocelyn's not here today, but she presents a lot of data back to the residents on how we're doing on a very consistent basis, which is hugely important. We now have a social media site, which I'm not any good at, but my residents dragged me into Instagram, and thank goodness they did, because I had no idea. And so that was another venue for us. It's on our website now. Okay, we talk about it, as Bonnie mentioned. You know, if you meet some of the criteria and the committee approves, you're recognized as a graduate of the academy at graduation. We specifically put that into graduation because we felt it was important. And so, you know, when I write letters for fellowship, I communicate to potential future fellowship directors that, hey, this is who you're getting. You know, they have participated in the academy. So because fellowship directors are going to want their fellows to teach the residents and teach the students too. And as Tammy pointed out, it's gold for recruitment. And I was reluctant at first to mention it too much at recruitment because I wanted to make sure that it was entrenched before I did. But we just started out during recruitment. You just say something very simple as, you know, who's taking an educational class? And you watch maybe one hand go up. Nobody has. And so there is a little bit of anxiety as our students enter into residency and are assumed to be teachers. They would like to know that the program that they're entering provides them with the basics of how to interact with their students on an educational level. And that's, you know, at the end of the day, that's really what we were doing. So, and all different types of venues too. You know, you can do PowerPoints during grand rounds. You know, they can be on different meetings. So, you know, get your idea into the agenda of different meetings. And there's all sorts of meetings. If your department's anything like mine, you got plenty of meetings. You know, text messages, pics, videos. There's all sorts of other ways to disseminate this, but you really have to over communicate. And then, as I was saying earlier, facilitate. You've got to be able to break down some of the barriers that you have, whether it be you know, a chief resident who, I didn't come here to spend my time teaching students, and you're like, okay, right? And so, you know, that might be a convo that you have to have, like, well, things are changing, you know what I mean? And because if you don't say something to folks that aren't on board with this change initiative, you're actually promoting not changing, right? So you have to find ways to remove barriers to where your change efforts aren't facilitated. And another thing, if you're a baseball fan, I'm not particularly a Yankees fan, but we don't need to get into that. But Yogi used to say all the time, it ain't over till it's over. So don't declare victory too soon. All right. And you may, you've got a year and you see some of your questionnaire data start to rise, and nope, no problem. As soon as you throw down your guard and stop trying to push your change efforts forward, the old guard will come right in and they'll say, we can go back to business as usual, doing what we used to, right? So don't declare victory too soon. It ain't over till it's over, all right? And you really have to enculturate what it is that you're change. We wanted folks to understand on the interview trail, particularly that at Baylor, residence as teacher is important. And it's something that we focus on. And it's something that we're proud of and our residents are proud of. And it's now in our culture. And that took a long time. I got here in 2014. It's 2022. I can't believe it, right? All right. So definitely recognize your early adopters, okay? And do that in faculty meetings. One slide and say, hey, I saw so-and-so, facilitating this student teaching, or, put your pictures up of your residents, or put some great feedback up from the end of clerkship evaluations, and talk about how, people are getting on board, but definitely recognize those folks. And it's important to recognize the leadership in your department too. Because if other people see their leaders getting on board with this, they're going to be more willing most times to get on board as well. And then, put your money where your mouth is. Okay. And so we did this, and I stole this idea, I think, from St. Louis. I did a conference at APGO, I don't know how many years ago. And one of the person that was either from SLU or WashU, and they said, we hand out an Overachiever Award. I said, that is the greatest idea I've ever heard of. And so ever since then, we've been handing out the Overachiever Award. And these are some of the residents that have received it recently. And it comes with a little Southwest gift card, not little. I mean, they can, get a move around the country or whatever that little jingle is. And so they really like it. And so it's a little, maybe you need a little extrinsic reward now and again, but it is nice to have awards. And Jocelyn has created also faculty feedback awards and clerkship kudo awards, and we have a professionalism award, and they seem kind of hokey, but academicians, for the most part, most of us are pretty competitive people. And so if there is an award to win, we're not going to say it, but we kind of want to win it. Even if it's like, you won the clerk, you're like, yeah, well, no big deal. And then you get home and you're like, I won the clerkship kudos award. You know what I mean? Even when we get older. So anyway, so we got to get out our worksheet, right, Bonnie? So we got to get out our worksheet.
I don't think we ever mentioned the worksheet, but
we didn't mention the word. Okay.
There's a worksheet where you can work through barriers at your own program, breakthroughs that you've had from this presentation, and then what are things, a blueprint for how you would implement this in your program, just like fresh from when you're done with this. If you write it down, it may be more likely that you get it. I'm putting just I think we have about 7 more minutes. I'm putting a link in the chat that kind of has some of the things we've talked about, the structured worksheets that we give to our residents, some of the articles we've used for our journal club, some of the manuscripts or scholarship we've gotten out of this, and then also that worksheet if you don't want to download it from SDS. So you can just go to that Google Drive.
Yeah. And then I think I just have a few more slides and then I'll behave. But if you're going to spend this much time, and really any, big change effort is going to take you some time. Sit down at the beginning of it, and you may need to reach outside the department. You may need to talk to other educators at your particular location to find out, hey, this is what I'm thinking of doing. What are some, measurable outcomes that I could look at that would strengthen the observations I want to make, or try to answer the questions that I have about residents as teachers, or whatever the change effort is. You've got to document this stuff. Otherwise, you will have done all this work, you'll be exhausted, and you won't have anything to show for it. And so here's some of, this was a lot of work. We started this a long time ago, and it's still ongoing. It's still something that we have to water. we have to motivate, we have to keep an eye on, if you want to know the truth. And I, I get these emails from JGME, and I was like, oh, what's the article of the week? I never heard this. And then I looked, and it was our article. And I thought to myself, oh my, I'm like famous now or something, right? I'm real famous. That and however much a cup of coffee will get you a cup of coffee, okay? But and this is the kicker too, okay? So you can see so the double AMC data is really important. Bonnie presented that earlier, okay? But this will get the attention of the highest level of leadership that you have for UME at your institution. You look at all med schools there, that's that top red line, and you look at strongly agree 47.3. Look what we did. Up and up and up and up and up and up. So it may not have all been the academy, but I tell you what, it really helped. Okay. So these are things that you can, if you like, our institution has, kind of an educational leadership award, you put up something like this. I mean, that's educational leadership. And that's making some change. And the very first year of graduates that I had here at Baylor, they used to get after me because I was, implementing all these changes. There was, we had some work to do. And so they got me a big piggy bank so I could put all my change in it. That's what they gave me. That was their graduation gift for me. And I have their picture over here by my desk. But here's some great literature that Bonnie has put together for us all. The top 3 are some of the things specific around the academy. And then there's some great OB-GYN specific educational articles there. And then I think some of our favorite too are here. But I think you should have a copy of the slides and stuff. And there are the kiddos. Those are my kiddos. I didn't get kiddos from Matt's kiddos are too small, and I didn't get Bonnie's kiddos. I should have got y'all's kiddos in here. But that's from Amelia Island. See, this is what we actually went. We were like, forget it. We're just gonna put our mask on. We're like triple boosted or whatever. And so I took Eli and Maya, and they dipped it was cold, the water, but they loved it. Anyway, here's to hopefully one day next year, this will be in person, because we do need some more social interactions. What else do we got? Do we have some good questions in the chat or anything, guys?
We have some compliments in the chat, which
Oh,
we
we do?
always appreciate too. I think we have about 2 or 3 minutes. Are there any questions? You can also just email us if you have specific questions about implementing this at your program.
So you guys implemented this sort of at the GME level, but with the coordination with the clerkship, right?
Yeah, you have to have buy-in from both. The first thing when we went to do this, I said, well, let's go talk with Jocelyn, who's our clerkship director, and let's go talk with our clerkship coordinator, right? Because we were going to do focus groups during the clerkship. At the end of the clerkship, we were going to need her help too, to get some of the students to volunteer for some of these focus groups. So yeah, we had to get their buy-in too. And they were, if you can do something that's going to improve the perception of the students on the clerkship, they were like, yes, please. You know what I mean? So it wasn't hard with them, that's for sure. At least I didn't think so. Bonnie, did you?
No, it wasn't hard at all. The clerkship people were very involved. And soon after we got the clerkship people involved, we actually presented the model to the residents and said, is this something you're interested in? Because if you're not interested in, we're not going to do this. But they were very interested in it. And that's where all of this started. So getting the key leaders and then the residents on board are the first steps.
Yeah, it's got to grow.
Yeah.
Well, I would just want to say this is so outstanding. You have so many resources here. I just want to highlight that in HUVA, you'll see not just like, yes, that Google Drive document, but your actual PowerPoint slide deck. I just want to highlight that to everyone as well that's there. Thank you for putting it up there, because there's so many things that are really helpful, like whether it's the 3 pillars or what the steering committee does or the 4 aims that you have, all those structural elements that are really important. I've been doing our RATS and curriculum model since 2011, and I am taking so much from what you've had and how you've packaged this, because it's just so well packaged and done. I'm super excited about that and kind of like scheming my own thoughts. So thank you so much for this wonderful, truly wonderful presentation. It was really, really meaningful. And I feel like you got so many compliments also from the attendees here. Oh, and I don't want to miss, maybe Jane has another question there.
Oh, it's just, can you send your resources?
Oh,
Like,
oh,
or
yeah,
your
yeah.
references?
Oh, so there's a Google link earlier in the chat. I can paste it again so it's fresher, but that link has the structured worksheets we use for our residents. It has the resources like the Sentinel literature we looked at, and the one JGME article actually goes through the structure of this program too.
Thank you
So
guys so much. Oh,
just shoot me an email, Jane, if you need anything else.
perfect. Thank you guys. Thank you, everyone. This was a wonderful
Okay.
workshop.
Have a good weekend.
Thanks for having us, and thank you so much for everybody being interactive. I really appreciate it.
Bye, everyone.